Welcome to the deep dive. Today, we're really getting into inflammatory arthritis.
That's right.
We've got some great revision notes here, and the plan is pretty straightforward.
Yeah.
Pull out the key high-yield stuff.
Yeah, make it stick.
Exactly. Make it easy for you to understand and remember, the essentials, but properly. Consider it your sort of quick reference guide.
Mm-hmm. We'll be covering the basics, what it is, the causes, who gets it.
Right, all the way through to management and prognosis. And we use these notes, inflammatory arthritis, notes for revision as our foundation.
Perfect. So we'll define it, look at etiology, risk factors, pathophysiology, the mechanism, basically.
Then differentials, what else could it be? Epidemiology, how common is it?
Clinical features, investigations, management, prognosis, and yeah, complications too. Should be comprehensive.
Great. Let's jump right in then. Definition. What exactly is inflammatory arthritis?
Okay, so fundamentally, inflammatory arthritis isn't just one thing. It's a group of chronic diseases. The real core idea is autoimmune.
Autoimmune, meaning the body attacks itself.
Precisely. The immune system gets confused, basically, and starts attacking the body's own joint tissues.
Ouch.
Yeah. And that attack causes inflammation in the joints. That's where the pain, stiffness, and swelling come from.
And it's chronic, you said.
It is. And over time, that ongoing inflammation, well, it can really damage the joint structure and mess up how it works.
So it's definitely not just simple wear and tear, like you might get as you age.
Absolutely not. That's osteoarthritis, a different beast entirely, though we'll compare them later. Key here is that immune system mistake.
Got it. And the notes mention specific types.
Yes. The main ones to keep in mind are rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. Useful categories.
Right. Okay, so that's the what. Now the why. Etiology. What causes this immune system mix-up?
Well, that's the million-dollar question, isn't it? The honest answer is we don't know the exact cause.
Ah, not straightforward then.
Not really. It seems to be a complex interplay. Genetics definitely play a part.
So it runs in families sometimes.
It can, yeah. Certain gene variations seem to make people more susceptible, sort of predisposing them. Think of it as maybe lowering the threshold for the immune system to react wrongly.
Okay, genetics.
What else? Environmental factors are strongly suspected as triggers. Things like certain infections might kickstart the process in someone who's already genetically susceptible.
And smoking. I saw that mentioned.
Yes, smoking is a big one. It keeps cropping up as a significant environmental trigger or risk factor for developing inflammatory arthritis, especially rheumatoid arthritis.
Interesting. So it's this combination, your genes plus something you encounter.
That's the current thinking, yes. A mix of nature and nurture, if you like.
Okay. That leads us neatly into risk factors. Who's more likely to develop these conditions?
Well, building on the genetics point, having a family history is definitely a key risk factor. Possessing those specific genetic markers we mentioned also increases risk.
Right.
And then there are demographic factors. We tend to see it more often in women.
Oh, really?
Yeah.
Is there a reason for that?
The exact reasons aren't fully clear, but hormonal influences are suspected to play a role. It's an active area of research. And the typical onset is often in middle age.
Late, okay.
And just to reinforce, those environmental factors we talked about, smoking exposure and potentially certain infections, are also considered important risk factors.
So summarizing risks, family history, female sex, middle age, and things like smoking. Got it. Now, pathophysiology. Let's get into the mechanics of what's happening inside the joint.
Okay, so the core mechanism is that autoimmune response we keep mentioning. The immune system targets the joint tissues.
The synovial, the joint lining.
Exactly, often the synovium initially. This attack triggers and sustains chronic inflammation within the joint space.
And that inflammation is the direct cause of the pain and swelling people feel.
Yes, but it's more insidious than just causing symptoms. This chronic inflammation is destructive.
Destructive how?
It leads to the breakdown of cartilage, that smooth, protective layer on the ends of bones. It can also damage the bone itself, right underneath the cartilage, and affect surrounding ligaments and tendons.
Wow. So it really dismantles the joint over time.
It can, yes, if not controlled. On a cellular level, you get this influx of immune cells, T cells, B cells, macrophages into the joint.
The body's soldiers, but fighting the wrong war.
Sort of, yeah. And these cells release chemical messengers called cytokines, things like TNF-α, interleukin-1, interleukin-6. These cytokines are powerful inflammatory mediators.
So they basically amplify the inflammation.
They do. They orchestrate and perpetuate the inflammatory cycle, which unfortunately drives the joint damage in these conditions.
Okay, that's a clear picture of the internal battle. So if someone comes in with joint pain and swelling, it's not always inflammatory arthritis. What else needs to be on the radar? The differential diagnoses.
Absolutely crucial. Top of the list is often osteoarthritis, or OA.
The wear and tear one we mentioned.
Exactly. OA is degenerative. It's about cartilage breaking down due to mechanical stress over time, not an autoimmune attack. The pattern of joint involvement and the type of stiffness are often different too.
Okay, OA. What else?
Gout, very different cause. Gout is caused by tiny crystals of uric acid building up in the joint, triggering intense inflammation.
Ah, so it's a crystal problem, not an immune system problem per se.
Correct. Though the crystals do trigger an inflammatory response, and then there's infectious arthritis, sometimes called septic arthritis.
That sounds serious.
It is. That's when bacteria or another microbe gets into the joint and causes an infection. It's usually very acute, very painful, often affects just one joint, and needs urgent treatment with antibiotics.
Right, so OA, gout, infection, key things to rule out.
Yep.
Good. Now, how common are these inflammatory conditions? Let's talk epidemiology.
They have a pretty significant impact, certainly here in the UK, if we just take rheumatoid arthritis, or RA, as an example.
Yeah.
And the prevalence is estimated to be around 0.8% in UK adults.
0.8%. That doesn't sound huge, but across the whole population.
Exactly. It translates to hundreds of thousands of people. It's a substantial number living with RA.
Wow. Nearly 1 in 100 adults.
Roughly, yes. And remember, that's just RA. Add in psoriatic arthritis, ankylosing spondylitis, and other types, and the overall burden of inflammatory arthritis is really quite large. It's definitely not a rare group of diseases.
Okay, point taken. It's common and impactful. So what does it actually look like for the patient? What are the typical clinical features?
Well, the classic joint symptoms are pain, definite swelling, you can often see its stiffness, especially after rest, and reduced movement in the affected joints.
Right.
A really key feature, especially in RA, is symmetry.
Symmetry, meaning?
Meaning if a joint on one side of the body is affected, say a knuckle on the right hand, the same joint on the left hand is often affected too.
Oh, okay. That's quite distinctive.
It can be. Common sites are the small joints of the hands and wrists, the feet, and also larger joints like the knees, but others can be involved too.
And it's not just the joints, is it? I remember reading about systemic symptoms.
That's right. These are autoimmune conditions, so they can affect the whole body. Fatigue is incredibly common, often quite profound.
Just feeling wiped out all the time?
Yes, a really debilitating fatigue. And morning stiffness is another hallmark.
We mentioned stiffness earlier. How is this different?
The duration is key. In inflammatory arthritis, the morning stiffness or stiffness after any period of inactivity typically lasts for a significant time, often more than an hour, sometimes several hours.
Longer than an hour. That sounds like a really useful clue compared to, say, the few minutes of stiffness someone with OA might get.
Precisely. It's a very helpful distinguishing feature. Some people might also experience low-grade fever or unintentional weight loss, especially during flare-ups.
Okay, so key features.
Yeah.
The joint symptoms, often symmetrical, plus that prolonged morning stiffness and potential systemic stuff like fatigue.
That's a good summary, yes.
Right. So someone presents with these features. How do we confirm it? What investigations are needed?
It's usually a combination approach. Blood tests are vital. We look for signs of inflammation circulating in the body.
Like what specifically?
We measure inflammatory markers. The main ones are C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR.
CRP and ESR. And they'd be high.
Typically, yes. They're usually raised when the disease is active. They reflect the level of inflammation systemically.
Okay. Raised markers. Didn't we have a mnemonic for that?
Yes, you mentioned one. Can elevated rates point to inflammation?
Ah, yes. Cheesy, but maybe helpful. What else in the blood tests?
We also look for specific antibodies. These can be really helpful in diagnosing particular types, especially RA.
Antibodies like?
Rheumatoid factor, or RF, is the classic one. And anti-CCP antibodies, that's anti-cyclic citrullinated peptide. Anti-CCP is actually more specific for rheumatoid arthritis than RF.
So finding those strongly points towards RA.
It does, yes. Though not everyone with RA has them, and RF can sometimes be present in other conditions or even healthy people. But anti-CCP is quite specific.
Okay. Bloods for inflammation and antibodies.
Oh.
What about looking directly at the joints? Imaging.
Yes, imaging is crucial too. X-rays are often the first step. They're good for showing established damage, things like joint space narrowing or erosions, which are little areas where bone has been eaten away.
So X-rays show the consequences, the damage done.
Often, yes, they might be normal early on. Ultrasound is increasingly used. It's excellent for looking at soft tissues and detecting active inflammation synovitis, which is inflammation of the joint lining, and fluid in the joint. You can see it in real time.
More sensitive for early inflammation, then.
Generally, yes. And then there's MRI, magnetic resonance imaging. MRI gives incredibly detailed pictures of both bone and soft tissues. It can pick up very early inflammation, even bone marrow edema, before damage is visible on X-ray.
So a range of tools depending on what you need to see. Bloods and imaging working together with the clinical picture.
Exactly. It's about piecing together all the evidence to get an accurate diagnosis and understand how active and severe the disease is.
Okay, so we've diagnosed inflammatory arthritis. What now? How is it managed?
Management has really transformed over the last few decades. The main goals are, 1, control the symptoms, the pain, stiffness, swelling. 2, reduce the underlying inflammation. And 3, crucially, prevent or at least slow down further joint damage.
Makes sense. How do we achieve that? Medications?
Medications are central, yes. We often start with NSAIDs, nonsteroidal anti-inflammatory drugs. Things like ibuprofen or naproxen.
For quick relief.
Yes, they're good for symptom control, reducing pain and inflammation fairly quickly, but they don't really change the long-term course of the disease.
Right, so what does?
That's where the DMARDs come in, disease-modifying antirheumatic drugs.
DMARDs, okay.
These are the cornerstone of treatment for many types, especially RA. Drugs like methotrexate, sulfasalazine, leflunomide, their job is to suppress the overactive immune system and actually slow down the disease progression and joint damage.
So they tackle the root cause more directly.
In a way, yes. They target the underlying autoimmune process. Then, if conventional DMARDs aren't enough, or for certain types of inflammatory arthritis, we have biologic therapies.
Biologics. Sounds advanced.
They are. These are genetically engineered proteins, often antibodies, that target very specific molecules involved in the inflammatory cascade, like TNF-α or specific interleukins we mentioned earlier. They can be very effective for people who don't respond well to DMARDs.
More targeted, potentially more powerful.
Often, yes. And finally, corticosteroids, like prednisolone. Powerful anti-inflammatories. We use them mainly for settling acute flare-ups quickly or sometimes as a bridge while waiting for DMARDs to start working. Usually short-term use if possible due to side effects.
Okay, so a toolkit of drugs. NSAIDs for symptoms, DMARDs and biologics to modify the disease, steroids for flares. What about non-drug approaches?
Absolutely vital. Non-pharmacological management is key. Physical therapy is crucial.
Physio, how does that help?
Helps maintain joint flexibility, range of motion, and strengthens the muscles around the joints, which provides better support and can reduce pain. Exercise, tailored to the individual, is really important.
Even though the joints hurt.
Yes, finding the right balance. Low-impact exercise is often recommended. Then there's occupational therapy, or OT.
What do they do?
OTs are brilliant at helping people adapt daily activities to protect their joints. They might suggest assistive devices, different ways of doing tasks, or splints to support joints. Really practical help for maintaining independence.
That sounds incredibly useful.
It is. And general lifestyle factors matter too. Managing stress, getting enough sleep, and as we mentioned, stopping smoking is really important. It's a whole package.
Right. So it's really a combination of the right meds, plus therapy and lifestyle changes, all working together here in the UK context.
Exactly. That comprehensive approach gives the best chance of controlling the disease, improving quality of life, and preventing those long-term problems.
Which brings us to prognosis.
Mm-hmm.
What's the outlook for someone diagnosed today?
It's quite variable, honestly. It really depends on the specific type of inflammatory arthritis, how severe it is when diagnosed, and crucially, how well the individual responds to treatment.
So no single answer.
No. But the good news is that with modern treatments, particularly early diagnosis and the use of DMARDs and biologics, the prognosis for many people is much, much better than it used to be.
That's encouraging.
Definitely. Early and aggressive treatment can often slow down or even halt disease progression significantly, allowing people to maintain good function and quality of life. Remission is now a realistic goal for many.
Remission, meaning the disease is effectively inactive.
Yes. Minimal or no symptoms, no active inflammation. However, We have to be realistic. Some cases are more difficult to treat, more resistant to medication.
Right.
And in those situations, unfortunately, people can experience persistent symptoms, ongoing joint damage, and functional impairment despite treatment.
And that can lead to complications, I imagine.
It can, yes. Let's talk about those potential complications.
Okay, what are the main ones?
Well, directly related to the joints, the ongoing inflammation and damage can lead to permanent joint deformities. Think, the characteristic hand deformities sometimes seen in long-standing RA. And this, along with pain and stiffness, causes loss of function.
Making everyday tasks difficult or impossible.
Exactly. A major impact on daily life. But the complications aren't just limited to the joints.
Because it's a systemic condition.
Precisely. People with inflammatory arthritis, particularly RA, have an increased risk of developing cardiovascular disease.
Heart attacks and strokes.
Yes. The chronic inflammation seems to play a role in accelerating atherosclerosis, the hardening of the arteries. There's also an increased risk of osteoporosis.
Thinning of the bones. Why is that?
It's multifactorial. The inflammation itself can affect bone metabolism, corticosteroid use contributes, and reduced mobility can also play a part. This increases fracture risk.
Okay, so cardiovascular issues and osteoporosis. What else?
Other systemic complications can involve the skin, like nodules in RA, or the rash and psoriatic arthritis. The eyes, causing inflammation like uveitis, and the lungs, sometimes causing inflammation or scarring.
It really can affect many parts of the body.
It really can, which is why regular monitoring and comprehensive management are so important, not just for the joints, but for overall health, to minimize these risks and improve long-term outcomes.
It underlines that treating the inflammation is key for both joint health and general health.
Absolutely. It's about managing the whole person, not just the joints.
Well, this has been a really thorough deep dive into inflammatory arthritis. We've covered so much ground, from the basic definition and causes right through to management and those potential complications.
Yeah, hopefully it provides a clear, high-yield overview. The key things to take away are probably the autoimmune nature, the importance of symmetry and morning stiffness as clinical clues, the role of investigations like bloods and imaging.
And the modern management approach, using DMARDs and biologics early, alongside physio and OT.
Exactly.
Yeah.
And understanding it's a systemic condition with potential long-term impacts beyond the joints.
It really makes you think, doesn't it? How the body's own protective system can go awry and cause such problems. It highlights why the ongoing research to understand these processes better and find even more targeted treatments is so vital.
Absolutely. There's still much to learn.
Well, hopefully this discussion has been useful for you listening. If you want to cement this knowledge or test yourself further, definitely check out PassTheMSRA.com.
And FreeMSRA.com too. Both excellent resources for revision.
Great suggestions. Thanks again for joining us on the deep dive.